So we can just have Mehmet and Sandeep to start the session. So we're just going to mute everybody else. Sandeep, do you want to ask questions from Mehmet regarding what was left the other day?
Yeah, so one of the questions was firstly about the recurrent disc. We were discussing that, and at that time the session stopped. So whether to fuse or not to fuse in recurrent disc, I think we had discussed that partially.
Yes. Recurrent disc is another issue. I didn't talk about that in my previous talk. In general saying, if it's the first recurrence, you can make either a discectomy again or a fusion surgery. But fusion is necessary if the patient had, after first primary surgery, had back pain attacks. And if he or she had morning stiffness, discogenic type of pain, and pain with coughing or sneezing, such symptoms. Additionally, radiologically, if there is a preservation of the disc height, if there are other instability signs like modic changes, severe facet joint degeneration, those patients may be a candidate for a fusion surgery. But in the second recurrence, I mean, the patient had a primary surgery, then a recurrent surgery, and then came to you again with a new onset of leg pain. In those instances, I always recommend a fusion surgery in the second recurrence, not in the first recurrence. Okay?
Okay. So another question was, how many levels you can decompress, do a decompression alone at one time without a fusion?
Without fusion. Yeah, you can make many levels. But if it is a minimally invasive surgery, there is no doubt that a minimally invasive surgery will not cause much instability. But if it is a open surgery and you remove all the lamina and a part of the facets, then you may think about you are risking the patient for a further instability. Some surgeons tell that in case they do 3-level laminectomy, they also do a fusion surgery. But I'm not for that, in the especially in the lumbar spine. But in the cervical spine, you can. In fact, with current evidence, we do not recommend in the cervical spine multi-level laminectomy alone. We always recommend a fusion surgery together with a laminectomy in cervical spine.
Mehmet, if I could ask a question, please.
Another question is,
Sandeep, can you hear me? Sorry.
Yeah.
So just this question was also written yesterday, was how do you prevent adjacent segment disease when you're operating?
This is a hot question. We don't know. There are no good evidences to avoid an adjacent level disease. But if you provide good doses, if you look at the site parameters nicely, this is the first thing we have to do to prevent an adjacent level disease. Second is somebody says that a mobility preserving surgery may prevent adjacent level disease. But I'm just doing as shorter as possible fixation to prevent it. Longer fixations are more prone to adjacent level disease. Sandeep, you are muted. Sandeep is muted.
Let's see what happened to him there. Yeah.
Sandeep, you must open. Yeah, okay.
Yeah, now I'm there. So one question was, do you recommend physical therapy after a disc surgery?
If the patient has no back pain, I don't do it. But if he or she has back pain attacks together with the leg pain, yeah, I can recommend. But I don't like that physical therapy with infrared application, ultrasound, and massage. Instead I send the patients to the physical therapist to show the patient an exercise program instead of that.
Okay. So do we have any other questions?
Maybe I can ask another question. What about, you see these young people and you've got very healthy disc. I was talking to many people from Korea, and what they do is when you have got very healthy disc and they operate, they put patients to bed rest for a week. And they say because of that, the chance of recurrence in young people is then reduced. Do you do that with your young patients who've got healthy disc with disc prolapse?
You mean fusion surgery?
No. If you have a healthy disc and a disc prolapse, patient has severe problems, you've done conservative treatment that failed, you operated on that patient, post-operatively, would you give them bed rest? And that's what Koreans say, that if you give them bed rest for a week or 10 days, then the recurrence chances are low.
I don't think it is an evidence-based thing. I don't see any information about that. I don't do it. Actually, in young patients, if the patient has no pain at all, you cannot leave him or her in the bed. It doesn't work, at least. I don't do it, simply.
One question is, how do you how do you choose between laminoplasty and lateral mass fusion?
Laminoplasty, if there is before surgery, if there is no neck pain, if the lordosis is nicely preserved, those patients may be candidate for laminoplasty. But if there are some instability signs, if the lordosis is not preserved, if the patient has neck pain before surgery, those patients are candidates for laminectomy and fusion.
And when do you think, if a patient has a foot drop for 24 hours, how much time it will take to recover after a disc surgery?
A real foot drop, actually, there is not a good consensus on what foot drop is, but a real foot drop is 1 out of 5 muscle power. In that case, we must do the surgery in the first 6-8 hours. If it's longer than 24 hours, the success rate is very low.
Okay, Sandeep, you want to start your presentation? Thank you, Mehmet. That was, your presentation was amazing. We enjoyed it.
And thank you for the questions. Thank you.
And thank you. And you will be coming and joining us again on Monday with Atul, and Sunday, if you want to hear the COVID neurosurgery thing, I will send a link to you as well.
Thank you.
Thank you, Mehmet. And so we'll start with Sandeep. Sandeep does not need any introduction. He's been on the front of teaching all over the world, and especially famous for working as a a big shot neurosurgeon working in Fortis. He has been amazing with some of the work he does, and we'd like to learn something from him regarding frontal gliomas. Sandeep.
Okay, so we start with the approaches to the frontal gliomas. So what we are going to discuss today is how to approach these tumors, which ones to operate, which ones not to operate, what kind of procedure to be done, whether it's a craniotomy or a biopsy, how much to resect, and ways to improve the resection and reduce the complications and increase the safety. What we are not going to discuss today is the pathology of the tumors, the post-operative management like radiotherapy or chemotherapy, because that will be for another day. So let's start with, so any patient that you see, your management will depend upon the location of the tumor, the size of the tumor, the clinical condition, and the Karnofsky score of the patient, age of the patient. So all these factors together will define your approach. Now, the investigation, the mainstay of the investigation is a contrast MRI. We use navigation in almost all our patients. So all the MRIs are anyway done in navigation format. In some patients with eloquent area tumors, we do DTI imaging and functional imaging. We do perfusion study in almost all our patients. Our chief radiologist, Dr. R.K. Gupta, has his own protocol for perfusion, and he has done a lot of research on that. So these are the papers published by us in last 5 years on perfusion MRI. And now we are reaching towards achieving a very good pathology correlation. And so we are working on that. So right now our accuracy rate is more than 95%. So these are the various papers that we have published on the same topic. So now there are several adjuncts to the surgery. What will help the surgeon? Microscope and CUSA have become sort of mainstay, and they are practically available in all the theaters. Neuronavigation is again now available in most of the modern operation theaters. Intraoperative MRI and more recently ultrasound has been there for some time, and they have their role, though limited. Intraoperative use of 5-LR has really worked wonders for resection of the residual tumor, but it is not FDA approved in North America. Again, glial wafers have been used to prevent post-op recurrence, and initially they were proposed for recurrent tumors, but now for the last 15 years they have been approved for primary tumors also. I have limited experience with glial wafers. Some had pretty good results and some did not. So I'm still not sure, and it is very expensive in our area. So I'm not still sure when to use it and when not to use it. How does navigation help you? As we have been using navigation for a long time, we know that you can precisely mark your incision and precisely make a craniotomy, identify the boundaries of the tumor before you resect so that you don't go into normal areas. It is particularly important in deep-seated tumors to get the safest or the shortest trajectory to the tumor. Rather than making a big opening and then looking around for the tumor, you know where the tumor is and you can directly reach there. And at the end of surgery, to define the boundaries of resection so that you know that you have done a good job. The only caveat is that in large tumors, there can be a brain shift, which can negate your findings, and there can be an error which can creep in. And for this, intraoperative ultrasound and MRI are helpful. The possible procedures that one can do in a glioma, the mainstay is the craniotomy and resection of the tumor. Second is stereotactic biopsy, which is reserved for certain group of patients. And thirdly, one can opt to do nothing. I see at least one patient a month where I ask them not to do anything. Patients might be very old with significant neurological deficit, very poor neurological status, where I don't think that I can actually make the patient, condition of the patient better by doing any surgery. So I just sometimes advise them to let the nature take its own course. Now, we start with stereotactic biopsy or image-guided biopsy. Image-guided biopsy can be done by neuronavigation. By stereotactic biopsy, you require a stereotactic frame. But we have both, but I particularly prefer stereotactic biopsy because you can get a very linear trajectory and you can enter the same trajectory again with confidence, while with image-guided biopsy, it is very difficult to get the same trajectory again. So it is particularly helpful. Suppose if there is a very small bleed, then if you're in the same trajectory, you can actually wash the area out. The indications for a stereotactic biopsy would be deep-seated lesions, particularly small lesions with patients with having minimal deficits, or when the pathology is a suspect. Sometimes it can be infectious pathology, you are not very sure, or particularly in lymphomas. In lymphomas, if you just can prove that it's a lymphoma, you really don't need to do a big surgery because they respond very well to chemotherapy and radiotherapy. And sometimes the patient is not fit for a major surgery. There can be occasional patient who really needs a surgery, but they are just not willing for surgery. They just want a tissue diagnosis and they want radiotherapy. So they would be a rare group of patients. I show you some examples where we have done stereotactic biopsy in the last few months. So this was a patient who was actually in altered sensorium and had left hemiplegia. Radiology was quite suggestive of a lymphoma. So we decided not to do a major procedure. We just did a stereotactic biopsy. It was a lymphoma and patient improved on radiotherapy and chemotherapy. Again, this patient did not have much deficit actually. He had minimal right hemiparesis and mild dysphasia, multicentric lesion. So we did a stereotactic biopsy. Again, it turned out to be a lymphoma. This was a 62-year-old female with minimal deficits. It was a small subcortical lesion. We did a stereotactic biopsy. It was a grade 3 astrocytoma and again underwent chemo and radiation. Again, a 70-year-old with a small multicentric glioblastoma. So it's a motor strip lesion. There's no point in removing this lesion. We are not going to really achieve anything and we just need a tissue diagnosis because this tumor is not causing any mass effect. Again, this was an interesting case. Patient underwent a renal transplant 1 year ago and was on immunosuppressants. And when he came for follow-up, during that period, he developed hemiplegia. Because he was immunocompromised, there was a doubt whether it can be tuberculosis. Though radiology was more in favor of a disease, we did a PET scan, there was no metastasis. Did a stereotactic biopsy, it showed a glioblastoma. Again, this is a patient, she's an 80-year-old doctor. I just saw her a few days ago. She presented with a history of dementia for last 10 years. And for last 1 month, she had stopped talking and recognizing relatives. And the MRI showed this picture. So the previous MRI was a month old. She had been on steroids for all this time. We repeated the MRI and tumor did not show any change. So initially I told them that considering her condition, neurological condition and age and the location of the tumor, probably let's just not do anything and just let's send her home. But the radiologist suggested that there is a chance that it can be a lymphoma. So we did a perfusion scan. Again, that was quite ambivalent. They said that there's a 50% chance of a lymphoma versus a glial tumor. So now we are planning to do a stereotactic biopsy later this week. Now, the mainstay of all these tumors is craniotomy. More than 90-95% patients will undergo craniotomy because they come with large tumors. So then essential equipment or which is desirable in your operation room would be definitely a surgical microscope, CUSA, neuronavigation. So these things are pretty much necessary if you have them. So use them. Intraoperative MRI, again, it is useful in selected cases. So we were actually the first hospital in Asia to have an intraoperative MRI brain suit from Brain Lab. And I think we installed it in 2006. We used it for 4 years. Gradually, the usage became less and less because we realized that it was useful in very few cases. It was increasing our OR time and practically we stopped using it after that. 5-align yellow dye, I don't have a personal experience, but many of my colleagues have a good experience with it and they were very happy with it. The problem was the dye was pretty expensive and anyway, for last few years now it is not available in India. So before we do the surgery, we have the MRI with us and how to approach the lesion. Previously, we used to make a skin flap and a largish craniotomy so as not to miss the tumor. But these days, we mostly give a linear incision after marking under neuronavigation, and the precise craniotomy is done after making a single burrow. I usually do a single burrow, only very rarely I make multiple when the tumor is grossly adherent to the bone. So we try to stick behind the hairline. You may take the incision across the midline to make a craniotomy right up to midline if needed, but we try not to come on the forehead. So either you can do a normal craniotomy, or sometimes we do a mini craniotomy, which is about 3 into 3 centimeters. This is reserved mostly for deep-seated or intraventricular tumors. We need 3 centimeters, so as once you open the tumor, you want to avoid any vein which is coming there. So you need a little bit more space. And we do this with the tube retractors. So the common locations of these tumors are frontopolar, frontotemporal, motor or premotor area, deep-seated tumors, sometimes going to basal ganglia and corpus callosum, sometimes the thalamic and intraventricular extension. So the surgical approach is different in different tumors, the goals are different, the risk and complications are different, and the amount of resection that you can do would be different in these tumors. So for frontal or frontopolar tumors, most of them we can remove them completely. You do a frontal lobectomy most of the times, along with the tumor excision. In frontotemporal tumors, depending upon the site and proximity of eloquent areas, you have to be careful about, many of these tumors are straddling the middle cerebral artery. So you have to be careful of avoiding any damage to the middle cerebral artery or its branches. In eloquent areas, perhaps awake craniotomy is the best answer. I operate all deep-seated and intraventricular tumors by a port, which is a real minimally invasive technique which prevents any damage to the cortical area. Now, extent of resection. How much do you resect? Many studies have shown that gross total resection has significantly improved prognosis as compared to subtotal resection. In initial studies in 1990s, there was a study of 500 cases where they showed that gross total resection or a resection more than 90%, actually 89%, was significantly beneficial. Other studies proved that there was more than 80% resection, which was beneficial. But now most people are agreeing on the fact that if a gross total resection can be done, that definitely improves the prognosis. But at least the resection has to be more than 90% to gain any long-term benefit. So how to achieve a gross total resection? Apart from the contrast enhancing area and the contrast even sketch which you would try to remove, I try to remove the abnormal area seen on the FLAIR images also, because there is a lot of microscopic spread of the tumor. And we use the same strategy while planning radiation also. So we take all the FLAIR abnormality into the radiation area. Navigation will help in marking out the boundaries of the resection cavity. Intraoperative MRI and more recently ultrasound can help in identifying the residual tumor, and one can remove further tumor in the same sitting. Similarly, dyes like 5-LA and fluorescein can help in identifying the residual tumor. So this is an example of a 5-LA dye. So this is the tumor. This is the resection cavity when the surgeon thought that the resection is complete. And this is the residual tumor here. And so you can see that the resection is pretty good. So I took this slide from my colleague, Dr. Rahul Gupta. Now I'll just show you typical frontal tumors. Like this is a 35-year-old female presented with headache only, underwent frontal craniotomy and a gross total resection. This is the post-op MRI. Again, a 55-year-old female with a deep-seated glioblastoma. We approached from the front, and so there is a slight residual disease here, but almost 80% tumor was removed. Again, a 72-year-old gentleman with glioblastoma. FLAIR showed the margins of FLAIR abnormality were far beyond the tumor contrast enhancing part of the tumor. So we did a pretty extensive resection. Patient did quite well. Again, this is a 35-year-old doctor with a grade 2 oligodendroglioma removed with the help of neuronavigation. Again, this was a very interesting 25-year-old female that I operated just last month. And this tumor was pretty extensive. The patient just presented with visual disturbance and diplopia. And the interesting thing was the tumor was extending right from the top of the skull to the bottom, and it was engulfing the whole optic chiasma, optic nerves, and it was even going into the sella. I had never seen a glioma going into the sella. So we did a pretty extensive resection, and the vision got better, and she is undergoing radiotherapy right now. Again, similar 65-year-old male. So what I want to show here is that in most of the frontal tumors, which are located near the poles or midline, you can do a pretty good resection. When the tumor has got extensive spread on the when it goes to both sides, then you are limited in your resection because you don't want to do a bifrontal lobectomy. Or when there is a spread which is extensive in the corpus callosum, again, then you are limited in your resection. Now, deep-seated intraventricular tumors. In all these tumors, we have been using a port made of a 5 or 10 cc of syringe, which is cut to the right depth, which is measured on neuronavigation, and it is inserted through a mini craniotomy. So we have a dilator. We load the syringe on the dilator, navigate the dilator, and then introduce the syringe till it reaches the tumor. It is a very cheap option, and it's just the cost of syringe practically, and you can make a new one in each surgery. So typically we would use the portal surgery in these kind of tumors. It's a thalamic tumor with a large intraventricular extension. You can see this trajectory here of the port. Again, a 58-year-old with glioblastoma, and we use this. Again, you can see the trajectory and pretty good tumor decompression. Again, a 15-year-old girl with a neurocytoma, and you can see we normally take a trajectory between at the junction of the parieto-occipital lobes, which produces minimal deficit, and you can enter the ventricle directly. This was again a 40-year-old male. This turned out to be metastasis from a renal disease. So sometimes you have to take unusual approaches. I'll just talk briefly about the supracerebellar transsensorial approach for medial temporal thalamic tumors. It was initially popularized by Vaishya. It is not a commonly used approach. I have used this mostly for territorial meningiomas and occasionally for gliomas. It gives an excellent exposure with minimal damage to cortical tissue. So this was a 4-year-old girl who presented with hemiparesis and diplopia. So this I had operated about a couple of months ago. And as you can see here, the tumor is quite deep-seated. Even if I use a port, this tumor is more on the right side. Even if I use a port, I will have to enter the ventricle, then I have to enter here. I was worried about the optic radiation too. And this tumor is more on the right side, but it is crossing the midline. But if you see the SAG image, if you take a supracerebellar approach, you go from here and you are right up to the tumor. You just have a very thin tissue of the posterior midbrain or thalamus. So I took this approach, and the tumor luckily was soft, and it was a pilocytic astrocytoma, and I was able to remove it completely. And the eye signs also actually improved after surgery. Now coming to awake craniotomy. What are the indications of awake craniotomy? It is a very simple approach. Lesions near the eloquent cortex, though stereotactic biopsy is also kind of awake procedure. For tumor surgeries, brain mapping is not absolutely essential, though it is done usually in epilepsy surgery, awake epilepsy surgery. But in the eloquent cortex region, sometimes you can do a brain mapping to provide added security. Though we don't use brain mapping, I just suppose if it's near a speech area, our anesthetist is talking to the patient continuously, asking him to do tasks, and whenever there is any deficit or any problem, then we stop the surgery in that area. The contraindication for an awake craniotomy would be inability to cooperate or communicate in very small children. If the patient is in a deeply confused state, so you cannot communicate with him properly, if the patient there has mental retardation, or if there is a significant language barrier. Sometimes with a highly vascular lesion where you expect some complication, maybe brain edema, then you don't do this. Or in very extensive tumors, sometimes you don't do that. Patients with obstructive sleep apnea or with morbid obesity may feel claustrophobic and may develop respiratory issues, and we may have to convert it into a general anesthesia. So it is better to avoid these patients. So these are typical examples of where I would do a awake craniotomy. This was a patient with a motor strip lesion. This was a patient who had been operated 2 years before. He had oligodendroglioma. You can see the previous craniotomy. Now he had a recurrence posteriorly and presented with hemiparesis. This time it was a grade 3 oligodendroglioma, but we came out safely. We did not actually increase his deficits, and over a period of time his power improved. is again a 26-year-old male with a grade 2 tumor near the speech area. So we did a craniotomy. Again, this was a 25-year-old male. The only symptom was seizure. There was no motor or sensory deficit, no speech deficit. If you see the motor tracts on DTI imaging are pushed medially beyond the margin of the tumor, so you know that you are pretty safe here. We did a craniotomy, kept on talking to the patient, and we were able to remove more than 95% of the tumor. The post-op MRI was pretty good. Now, what are the complications that you can see in a craniotomy? The main complication that we face is the focal or generalized seizures, aphasia, motor sensory deficits, bleeding, sometimes brain swelling. It may need conversion to general anesthesia if there is any complication. So the patient's position and everything should be in a way that the anesthetist can easily convert it into a general anesthesia if need be. If the patient has seizures, it can be controlled by irrigation with ice cold saline on the surface of the brain, which should be ready on the trolley when you start the tumor excision. Seizures can be a problem if they are not controlled well during surgery, and one may have to restrict the amount of resection, which happened to me in one young female who had a left-sided perisylvian tumor involving the speech area. And patient started having seizures, which got controlled, and then she again had seizures, and sort of she was having continuous seizures one after another, sort of minor status, you can say. So ultimately we had to stop surgery, and the resection was just 50-60%. And later on she kept on blaming me for not doing a good job. But this can happen sometimes. Suppose if you are not doing an awake craniotomy, perhaps you can continue to remove the tumor because you are not scared at the time. So, and before concluding, when not to do a surgery, sometimes the patients are in a very bad condition, significant medical issues, deep-seated tumors with gross extension, bilateral big extension, and patient is Karnofsky score. So we take Karnofsky score 40 as a limit, and we don't do anything which is below 40. And recently, a couple of months ago, I had operated a patient who had ejection fraction of 25%. He had a large motor area tumor, and he presented with hemiparesis. I know, we thought that if we decompress the tumor, patient might get better. So when we opened it, there was a big vein straddling the tumor. We avoided the vein, went up in front and behind the vein to preserve the vein, but yet patient had post-op venous infarct, so which we had to evacuate. Patient improved again after that, though it took a long time. For 15-20 days, he was in ICU. So he got better, but ultimately died of a myocardial infarction. So sometimes you wonder whether you should actually operate such patients or not. So now to conclude, many frontal gliomas can be safely resected completely or near completely. Use of modern equipment like neuronavigation has improved both the safety and the survival of the patients. In deep-seated tumors, minimally invasive techniques can provide gratifying results with minimal deficits. And adjuncts like intraoperative MRI and intraoperative dyes may be helpful in some cases. So thank you.
Thank you, Sandeep. I think it was very extensive talk, and really impressive, the good work that you're doing. From the resident's perspective, for example, if it's a frontal tumor, where would you go? Where would you think about going that, I'm going to do this with image guidance, or would you use image guidance in every case?
Like a typical frontal polar or temporal polar tumor, where you just have to do a lobectomy, I really won't use image guidance. But if the same tumor is going behind and invading the corpus callosum, then image guidance helps you to actually know to what depth you have gone. But most of the deep-seated tumors, motor area tumors, any eloquent area tumors, will definitely use image guidance. Occipital tumors.
Okay, there's a question from Kumar. He's asking, in your experience, when do you do post-op MRI? Same day, 72 hours, and why? And what about, do you do frozen section in every case? And do you change your trajectory? So you start with MRI. When would you do a follow-up MRI? 24 hours, 72 hours, and why?
Now our protocol is that we do a follow-up MRI in every patient next day of surgery.
Why?
Because next because at time it gives you the best indication of what you have removed and what is the edema. Because if you do it later, then for radiation it may become an issue, because then they can't be absolutely sure about the tumor margins. Same day we don't do, because logistically it becomes difficult sometimes. And as far as frozen section is concerned, we don't do frozen section in any patient until in stereotactic biopsies we do it in every patient, and once the frozen section report is there, then only then we close. And in last 7 years we did not have a single negative frozen section, and a single negative stereotactic biopsy. Now in open procedures, when you are sure that you have removed the tumor, we really don't do a frozen section, because it will be just a waste of time. By the time report comes, you are already finished the surgery. So
okay, so there's a question about motor strip surgery. That if you have a motor strip tumor and then you're operating with awake craniotomy, what are the special things that you need to consider, that I'll stop if this happens and I'll continue if this happens? How do you decide that, or you depend on your neurophysiologist?
We don't do neurophysiology, as I mentioned before. We don't do the brain mapping at the time. We don't have MCRs here.
Okay.
Yeah, but see, the thing is, our anesthetists have been doing awake craniotomy for the last 15-20 years with us, and so they are very well versed with it. So they keep the patient engaged. They keep on asking the patient to do activities. If it is near speech area, they keep on asking, talking to them. Motor area, they keep on asking them to move their hands and legs both. And in parietal region, similarly asking them to do calculations to see how their function is going. If any time we see any dip in the function, we stop, and if it improves, then we proceed with the surgery. But if we don't see any improvement, then again neuronavigation helps. So we stop surgery in that area, and if you know that we have not yet significantly removed the tumor, we go to the other areas and continue with the surgery.
Okay, another question. What is your guidelines for giving incisions on gyri or sulci, or do you always go through sulcus, or would you go through a required?
As far as possible, we go through the sulci, and but if it's the surface tumor right there, so it doesn't really matter.
And the question to follow that is that if you have to give an incision on gyri, what lines do you use? Is it horizontal, vertical, or oblique, or how do you decide?
In the direction of the gyri.
Okay. And then we have a question that, this is from Musabir, who's asking regarding the grade of glioma. Low or high grade, would that affect your decision making and how much you'd resect or not resect? So if you send us frozen and it turns out to be a low grade or a high grade, would that make you decide you're going to take it out completely or incompletely?
I don't think the grade of the tumor affects my decision, because I try to remove all the tumor whenever it's possible, because that gives the best result. In low-grade tumors, if you remove it completely, some people have shown that the recurrence they can avoid radiation also, and the recurrence with or without radiation is practically the same. So in low-grade tumors, when we have removed it, though our radiotherapists don't agree, they want to give radiation to everybody, but sometimes we don't give radiation. I've seen that the patients do quite well, and the recurrence is after 4 or 5 years as usual. But in high-grade tumors, many papers have now shown that the amount of resection will affect the long-term prognosis. And the more you remove, and particularly more than 90%, it is not possible to remove 100% in all the patients, and in deep-seated tumors, sometimes it becomes pretty difficult. But at the same time, you have to consider the neurological status of the patient. Also, you don't want to create new deficits in a patient who did not have any deficits pre-op. His life expectancy is, anyway, you think, not more than 1.5 years. You don't want him to be paralyzed during that period. So preserving the patient is also very important. If you don't have the facility to all these things to really check the margins or the resection status, I think you should just be safe and remove whatever you can do safely.
Okay, we have our friend Parthiban, who's asking a question to Sandeep, that transsulcal approach he likes to do, and sometimes there is overshoot of the navigation tip, and your tip is going beyond the margin. What is your comment on that, Sandeep?
Beyond the margin of the tumor?
Yeah. You've got overshoot of big because when you're operating, you're going transcercal. So
yeah, sometimes that happens, but see, it is not as precise as radiosurgery, right? So the tumor is in front of you. Even if you shoot up, so navigation has its own issues, particularly in surface tumors. It's a small surface tumor. You can be completely misled by the navigation, and you may go in front or the back of the tumor. You can completely miss it. So these are the caveats with navigation. But with experience, you know, so you don't 100% rely on that. It is just to guide you.
Okay. The next question is about how about stimulation of the motor cortex or speech area? Do you use any stimulation? And if you do, what current setting do you use?
No, I already mentioned before that we don't use that, but many other people do use it. And I can't comment on the current setting, but of course it is helpful. You can actually, before removing the tumor, you can map out the area, speech area or the motor area, and you can avoid resection in that area.
Okay, there's a question from Arijit Chakrabarti, and his question is that if you're not using image guidance or you don't have any other thing, but you have a microscope, how do you differentiate between a tumor and normal tissue?
Yeah, sometimes the tumor is necrotic. You can actually see the difference and you can differentiate. But sometimes, particularly in low-grade tumors, it becomes very difficult to differentiate. So you just have to go by your anatomical knowledge and what you have seen on the MRI and correlate with that.
Okay, so then there's a question about stereotactic biopsy. Do you use a CT or MRI for stereotactic biopsy? And what software do you use for calculating? Is it manually or is it an MRI console or a CT console?
So we usually use CT, but because most of the tumors are seen on CT, but some tumors like this 80-year-old lady that I showed, I'm pretty sure that this won't be seen on a CT scan properly. So in these patients, we do a CT and MRI and fuse them both. So we do them in Medtronic software.
Okay.
But when we do only on CT, then we simply do it on the console because you just need to get XYZ targets.
So the question is, how much of contralateral lobe tumor do you remove after cutting the forks or by going underneath the forks in case of high-grade butterfly glioma? Do you remain aggressive or you are conservative?
So those tumors which are in the ahead of the ventricle, that means in the near the poles or in the frontal lobe. So then I either cut the forks or go beneath the forks and remain intratumoral and remove as much as possible. But if it is going behind, going into the corpus callosum, then I'm worried about the branches of the A2 also. So I'm not that aggressive there, but I try to remove whatever is possible.
Okay, you've seen Vlad's approach, in which he, if you have a tumor which is lying next to the forks on one side, he would approach it from the other side and take it out by cutting the forks. What do you think about that approach?
Yeah, I have done that few times. Okay. It's good.
And do you use CUSA in every case? And if you do, does your type and consistency of tumor, does that matter for you? And what about eloquent area? Would you use CUSA there?
So I have CUSA ready in most of the cases, but many times I don't even need to use it because the tumor is very necrotic and you can simply suck it out. Particularly in grade 2 tumors, when the tumor is slightly firm, then CUSA is very useful. Even in necrotic tumors, CUSA will just make it faster. So it's not necessary that you use it in every case. In eloquent areas, I am more worried about using CUSA, particularly at high speed, and more so near the sylvian vessels. You can easily damage a vessel if you are using that high power.
Okay, so Parthiban is asking, Jyoti is asking a question regarding yellow dye. Do you rely on it? You just said that you don't use it.
We are going to start using it in near future because we just got the equipment for that, but in between the corona came, so we are supposed to start it now. 5-LI is not available, so that's why we were opting for yellow dye.
5-LI, people were getting it quite cheap from China, but obviously not the actual Ella, which is charging a lot of money, just like any other big thing. Arshad from Bhavalpur is asking a question: if the tumor is on the speech area, and you check it, and every time it's on the speech area and it's an eloquent area, and you can't take it out, do you have any tricks to get out of this scenario?
You're talking about during surgery or before surgery?
Yeah, during surgery.
Firstly, I would do a awake craniotomy in such situations, but every time if suppose, see, if you are inside the tumor, then when you are removing the tumor, nothing should happen. Only when you are transgressing the boundary of the tumor and going into the normal area, patient will start developing deficits. So as I would try to remove as much as safely I can, but if wherever, suppose if I go on all this side and still patient is developing deficits, then I would leave it and give radiation later on.
Okay, so we're going to have two more questions. There's a question about frontal opercular gliomas with insular extension. What is your strategy to prevent injury to the white matter tracts or to perforators?
Again, we have to go very carefully there. You don't use CUSA there. So I just dissect with a very fine bipolar, and slowly I keep on dissecting the tissue till I've dissected the vessels from the tumor. And navigation also helps just to mark out the boundaries of the tumor, and then you don't transgress that.
Okay, so the last question is about your syringe port system using the tubular system. The question is it available on YouTube? And yes, there are many videos available on YouTube from different people. And I think I saw Sandeep's video there on the YouTube as well. So I'm sure you people can go and see it. And the article from Sandeep is very nice. And we just recently wrote a review about it as well. And I think that all.
I think we published it in World Neurosurgery.
Yeah.
I basically learned the technique from my colleague, Dr. Ranapate, who actually developed it. And he has been doing it for the last 10, 15 years now. So.
Okay, when do you leave a bone flap out if you see a lot of brain swelling?
Yeah, if there is a lot of brain swelling, we don't put the bone flap back. But sometimes if the bone flap is very small to begin with, by not putting it, it's not really going to help you. So very rarely, we have to convert it into a decompressive craniotomy.
Okay.
But I don't think we have seen that in the last many, many years. So.
And we have one more question is, what's the incidence of intraoperative seizures in awake craniotomy, and how worried are you? And how can you reduce the incidence in these patients of seizures?
So we load them with anti-epileptics anyway. And as I said, ice cold saline really helps in controlling the seizure used. So ice cold saline is just ready loaded as soon as you start touching the tumor. And if there is a seizure, then you just irrigate the area with it, and it stops almost immediately. So I have had intraoperative seizures in last 1 year. I remember in 2 patients. In one patient, I had to leave the surgery because she was going into status. And the other patient that I showed, that young man with a 25-year-old man, where the tumor excision was more than 95%, he had seizure. We controlled it. We proceeded with surgery, and after that, he did not have any seizure. So we could do a pretty good job.
Okay, I think Sandeep, we are really grateful that you gave such a comprehensive talk.